Welcome to this edition of Remarkable Conversations, a series that unites leaders driving change across cardiovascular medicine. There's no denying that the cardiovascular workforce is at a breaking point, and the impact on patient care is real and growing. Across the country, clinicians are under intense pressure, facing a crisis that demands new thinking and bold action. This isn't a new issue. In fact, the ACC has been working to address these challenges for nearly 20 years. But today, a perfect storm of aging patients and providers, rising disease complexity, heavier regulatory burdens, and burnout is pushing the system to its limits. Today, I'm privileged to be joined by Drs. Tom Maddox and Lakshmi Mehta to discuss this crisis, potential solutions, and the college's continued efforts to mitigate some of the biggest workforce challenges. Dr. Mehta is chair of ACC's membership committee and has played a critical leadership role in the college's advocacy and clinician well-being work. Dr. Maddox is a member of the ACC's Board of Trustees and recently chaired a special workforce task force. Thank you both for joining me. Let's dive in. Dr. Maddox, the ACC Board of Trustees task force identified several areas to address. What are the most pressing challenges currently contributing to the workforce crisis in the U.S. and globally?
Yep, and thanks for the opportunity to have one of the remarkable conversations. You're right that the workforce crisis continues unabated, and there's actually some current pressures on the workforce that make it an even more acute issue. We did have a workforce that convened a couple of years ago to kind of assess the specific factors that are driving some of the current strains on the system. And what we uncovered were a variety of factors on both the supply of cardiovascular clinicians and then the demands that those clinicians are facing in today's practice environment. On the supply side, we identified four major areas. One was that the training and certification pathways that our trainees and our attendings face are often quite long, arduous, and potentially not needed in terms of the overall length of time spent in training. We also identified a trend towards hyper-specialization. We're finding that many people are getting a lot of subspecialty training, which obviously speaks to their interest, but at the same time ends up taking them out of general cardiology pools and unable to manage a lot of the typical cardiac patients that we see come into our practice environments. The third area is that there is both a real and perceived lack of sufficient work-life balance in the current practice of cardiology, and that is either causing trainees to decide to pursue other clinical specialties besides cardiology, or for those folks that are in cardiac specialization, either moving to a part-time status or in some cases even retiring early. And then finally, we see that there's insufficient supply of trainees, not only MDs and DOs, but a variety of cardiovascular allied health professionals, including APPs, nurses, cath lab techs, echo techs, and other critical members of the team. So those are the four areas that seem to be most acute on the supply of our cardiovascular clinicians. And then on the demand side, I think we're all aware that our patient population has arguably never been older and never been sicker than they are at this current point in time. And we're seeing that in terms of when we look at our hospital data, rising case mix indices. We're seeing that the average age of patients in our hospitals and in our outpatient clinics has never been older, and the number of comorbidities that these patients experience, not only cardiovascular but non-cardiovascular, continues to increase in number. Similarly, we're seeing an increased number and complexity in the types of cardiac interventions that we can provide. In some ways, we enjoy a bounty of interventions, both pharmacologic and procedural, that we can bring to our patients' cardiovascular conditions, be it coronary disease interventions, heart failure interventions, structural heart disease interventions, or arrhythmia interventions. But with this increasing number and complexity of treatment options layered on top of an increasingly older and sicker patient population, it does mean that the amount of time and thought needed for each individual patient is increasing, and that is being squeezed with the decreasing amount of time that we have to attend to each individual patient. And then finally, of course, we know that there's a lot of financial thunderstorms in the current environment. We're all worried about the continued decrease in revenue, both in the commercial and government side of the payer environment. And this reduced reimbursement means that the amount of revenue that we can generate for each of our patient encounters continues to not be matched with the costs that it takes to deliver that care. So I think these are some of the current features that we saw in our investigation that our workforce is currently facing.
That's great. Let's dive deeper into each of those elements. Let's talk about length of training. What are some of the things that ACC can do to work on that issue in particular?
Well, I think starting with our training pathways, we know that there are probably some ways that we can reduce or at least better target both general medical training and cardiac specific training to be more efficient, while at the same time certainly not sacrificing the quality of the training and the competency of the practitioners at the end of their training period. So one relatively recent example is a pilot that was done for EP trainees, where instead of typically doing the 3 years of internal medicine, 3 years of general cardiology training, and then often 2 years at least of EP training, we started by trying to trim 1 year off the general cardiology training, recognizing that a lot of our EP practitioners need to have most of their focus on EP-specific procedures and care. And so as a result, they moved to the so-called 2 and 2 structure, meaning that the overall amount of time spent in cardiac-specific training was reduced from 5 to 4. And by doing that, and speaking with the trainees that went through that experience, we found that it did improve the efficiency without sacrificing the quality of the care they provided, and we were able to actually see some of those results published in an article in JACC back in 2022. So I think our Lifelong Learning Oversight Committee and some of their subcommittees that are focused on training pathways, COCAT, some of the other certification pathways, are taking those lessons and thinking about how they might apply them to the variety of training pathways we have in cardiovascular medicine to see if we can start to realize some of those efficiencies and allow for a less arduous amount of time spent in training and get more practitioners into the workforce. So that's one example.
Yeah, there's also, I understand, a pilot to shorten general medical training to 2 years, followed by cardiology. That has not been taken up by many programs as of yet, but certainly we've had recent conversations with the ABIM. They are interested in shortening training periods as much as we are, so hopefully that is a path forward. Let's turn now to hyper-specialization. I'm sure you see that in your program at Ohio State, Dr. Mehta. How have you encouraged your trainees to consider careers in general cardiology?
Yeah, thanks, Dr. Kramer. That's been a challenge, actually. I think that some of our trainees feel that hyper-specialization allows them not to focus on the other areas or higher salaries. We try and invigorate them, though, with the fun and the excitement of taking care of a whole cardiovascular system for our patients, as well as getting them involved in other aspects that can allow them to not feel overwhelmed. So with other technologies, and also looking at it from a population health of how, if you do general cardiology, you may be able to touch more lives than you think just with one disease process of super specialization. But it's a challenge to get people to want to do general cardiology.
Certainly there are plenty of general cardiology jobs out in the workplace, and so that should be an incentive there. Dr. Maddox, any comments on this issue?
Yeah, I think that's right. I agree with Lakshmi that we are challenged a bit in that people do like to get super specialized and find some enjoyment, as well as some knock-on benefits in terms of higher salaries, et cetera. if they're very focused on structural heart disease or EP or other subspecialties of cardiology. But certainly in my clinical role as a general cardiologist, I do find the variety to be quite enjoyable. And when I talk to a lot of people, I think they do say that the breadth of practice and the types of patients and issues that you encounter does keep practice sort of invigorating and enjoyable, and not quite as rote. I also think that there are ways to get deep expertise while not abandoning your overall identity as a general cardiologist. I know there's a lot of debate about all the different areas of cardiology at play now: cardio-oncology, sports oncology, cardio-rheumatology is the latest one I heard of. But certainly in our organization here at WashU, all of those fit under our section of general cardiology. And even though they do become expert in a deep area, they remain connected to the general cardiology field, and I think get an opportunity to both go deep and maintain that breadth and variety that is enjoyable about general cardiology. So that's, as we talk to our trainees and sort of counsel them on career paths for them, I think that's the pitch that we make that does seem to resonate for folks that could maintain a general cardiology practice.
In addition, because of the workforce shortages, even if someone becomes hyper-specialized, like Dr. Maddox had said, because there's a shortage of general cardiologists, the specialists have to practice general cardiology at our institute too. I mean, you can't run away from the general practice of it. So I think like there has to be some sort of balance, and that's where team-based care comes in, as Dr. Maddox had shared. If you don't, you need the ultimate team to help find the value in general cardiology.
Yeah, while we're on that topic, I mean, that's something that the ACC and MedAxiom has really been behind, encouraging models of team-based care. Do you want to talk more about that?
Yeah, I mean, at my institute, I'm fortunate to run our lipid program, and so that's a great example of team-based care where we get to practice with our pharmacist and the cardiologist in managing that patient as a whole and being able to leverage the skills that we each bring to the table for the patient, also incorporating dietitians. In cardiology, there's so much team-based care. I mean, there's heart failure, structural disease, and I think if we want to look at the future, because I think it's a somewhat bleak with the workforce shortages, is to think of how do we leverage everyone to be part of that team, to practice at their top of their license. And it goes beyond just cardiologists and APPs. I think it has to be dietitians, the pharmacists, even counselors for our patients' behavioral specialists, and even our community health workers to kind of engage beyond just the inpatient and in-clinic visit to something beyond that.
The other way we can expand our workforce is to make better use of our older cardiologists. As you know, we're aging as a specialty. The average age is in the late 50s of cardiologists at the present time. So engaging cardiologists who might otherwise be considering retirement in part-time work or less call, et cetera, just to encourage longer careers to, especially in general cardiology. Tom, any thoughts there?
I couldn't agree more with what both of y'all have said. From my point of view, I think we probably need to take more of a systems-based view of cardiovascular practice, more so than we have in the past. When you think about the historical practice of cardiology, it often has sort of centered on the physician, on the cardiologist, and that the idea has been that one person does everything for the patient that is needed, often within our pretty traditional settings of either a clinic or a hospital. And I think what the crisis is forcing us to do, and I think this is a productive thing to do, is to start to frankly disarticulate that kind of clinical encounter and think about how we might be more creative in spreading what needs to happen for a patient out across different people, taking better advantage of technology to assist us, and then consider different ways of using our time and the geography of care just in different ways. So specifically, we've started to use more of advanced practice professionals and other folks like what Dr. Mehta just mentioned with dietitians, physical rehabilitation folks, counselors, community health workers, really start to think about some of the ways that we can provide cardiovascular care through those professionals rather than relying solely on the MD or the DO. I also think that a lot of the administrative tasks, which seem to increase every year, really are ripe for more automation and technological offloading. At our system, and I know a variety of systems around the country, people are starting to experiment with things like more templated care, letting the EHR do more of the automated documentation that is part and parcel of cardiovascular practice today. We know that there's some promising initial approaches with generative AI in terms of writing notes for us or helping us with orders or even billing. And I think really pushing hard to see how we can let some of these newer technological approaches offload some of the, what I call administrivia of clinical practice is really important. And then I think we've seen some really exciting examples of moving the more chronic disease management tasks of cardiovascular care, hypertension management, diabetes management, lipid management, and really starting to move those to organized programs that often use asynchronous methods of working with patients rather than simply relying on them coming back periodically to a clinic to allow for tweaks to statins or blood pressure medicines. Instead, putting them with an asynchronous sort of program that reaches out often through SMS messaging or phone calls or other ways of communicating with patients, and letting pharmacists and nurses, which frankly are a little bit more efficient than docs, in getting patients to their optimal medication dosing or instituting the lifestyle changes that we know need to happen for those chronic conditions. I think really thinking creatively and having the clinician turn into sort of the systems expert and captain of the team, allowing for the deployment of all these resources in creative ways, are ways so that we can both more efficiently deliver care to more patients. And frankly, for me anyway, provides an interesting way to practice where you become not only thinking about how you manage the individual patients in your practice, but also optimize the system that can collectively deliver the care to your panel. So these are things that I see as pretty exciting opportunities for team-based care that would also have an impact on some of the drivers of our crisis.
Yeah, just going back to, you mentioned use of AI in our practice. Just in our practice at UVA, just in the last 6 to 9 months, we've incorporated a AI software where you start the software when you walk into the room with a patient. It's essentially recording the conversation and turning it into a note. Improves efficiency, reducing pajama time, and people have their notes done at the end of clinic.
It's a game changer. I've been using ambient AI for the last 1.5 years. It requires you, though, for change management. Most of us seasoned cardiologists who went from paper charts and dictation to electronic health records had to adjust to the change then. This is really a revolution in the way we're going to be practicing. But it requires to let go of perfection, and I've seen people struggle with that aspect of ambient AI, but it's exciting. And like to Dr. Maddox's point, when it starts doing our orders, just think of all the unnecessary administrative things that we do. It's going to be taken away, and we can actually put our cognitive load towards our patients. And it'll be exciting when it does some of the algorithmic stuff and then the population health that Dr. Maddox was saying. And so can it tell us, like, which patient are we missing the ACE inhibitor or ARB, and can we actually provide equitable care? So I'm excited, though, even though there's a workforce shortage, I think it's a time that we can make a difference here.
So you mentioned burnout, Tom. Lakshmi, you more than anyone else in the college, you've really focused on solutions for burnout. Do you want to mention some of those?
Yes, I mean, burnout happens for a lot of different reasons. And I think most organizations simply put it on the individual. And so here's some things to fix you as an individual. And yes, there are things that we need to do to be more resilient and adapt to the changes that are coming and the load and work-life integration. But there are the systemic things, and so that's what we were just discussing with how do we reduce some of those unnecessary administrative tasks. But one other key aspect is that we often overlook, and what Dr. Maddox had said was the cognitive load of each individual patient. The amount of medications, the amount of thought we need to do, we need that. And that's where this whole conversation of team-based care, AI, how do we use it, leverage it? I'm really excited, and I hope our early career and fellows in training really embrace and leverage how to use technology, and also not to run away like many of us did originally and complain about it, but how to embrace it to actually improve the care that we provide and improve that integration for work life. But burnout is a challenge for our organizations and as individuals, but another aspect within medicine that impacts the well-being of the entire cardiovascular care team is the mistreatment that exists in cardiology, and we've published on that people that feel mistreatment are more likely to burn out. And the reality is that more than 3 out of 4 cardiologists in the U.S. experience some sort of mistreatment, whether it's discrimination, harassment, or incivility. Until we adjust that culture in medicine, I think we're going to struggle with burnout because we're not going to feel like we belong, and that's just a tipping point to all these other external stressors we experience.
I'd like to turn now to advocacy and a lot of the work that our advocacy team is doing to combat some of these workforce issues. Either of you two want to tackle that?
Sure, I can go first. We obviously have a strong advocacy group at the college. They are always looking at the various policy issues that are at play in Congress or at various levels of government to see how they might impact cardiovascular care positively. And I think specific to the workforce, there's several issues that the team has identified and is working hard to advocate for amongst our elected representatives and other folks who are influential in policy. I think the first is back to this idea of a broader cardiovascular team. How are we ensuring that we have the right both reimbursement and regulatory policies in place to empower people like APPs and other allied health professionals to allow them to practice as independently as is appropriate, and thus expand the number of practitioners that can reach out to the ever-growing number of patients that need our services. I also know that there's a lot of policies at play around supporting the clinician well-being and ensuring safety for both patients and clinicians that would support some of the things that Lakshmi was just mentioning about mistreatment. And then finally, we know that there are some probably unnecessary barriers to allowing mobility of our workforce and have people go to where the need is greatest. And some of that is mired by the fact that there's a lot of non-competes that health systems and hospitals put on cardiovascular practitioners. And we're working to release those that we feel are inappropriate or antithetical to our practitioners. We also know that we need more in our pipeline. So we're working to also advocate for increasing the number of GME-funded residency and fellowship spots so we can generate more practitioners for the future. So those are some of the main issues that our advocacy team is focused on and pushing hard for. Lakshmi, what other things have you heard about?
Yeah, I mean, first off, people don't want to talk about politics these days and get nervous about it. But I think, the college has been on the front end of advocacy for years. And there are so many things that we've already done that have been important. We have advocated for care team members to supervise cardiac rehab. Just think about how much that unloaded some of the burden on us cardiologists. The college has also advocated for the Lorna Breen Act and to allow mental health assessments and people to not feel burdened by that. And at the state level, advocating for revisions in the state medical board questioning about prior mental health conditions. We've advocated for workplace safety so that it is a crime to attack a healthcare worker. So those are like some of the things that advocacy can be helpful. But I say that, if you want to make a difference in the field, you're going to have to participate in the advocacy efforts. Whatever side of the politics you're on, we and the college advocate for the care of our patients and for our own profession. So it's essential, and if we're not participating in it and promoting it, then it's more likely cardiology will be on the menu of what the legislators want rather than being at the table and advocating for what needs to be done.
That's a great point. I want to also mention that the college is hosting 2 side meetings during the UN General Assembly in New York in September that are focusing on workforce issues around the world to address the global burden of cardiovascular disease and focus on non-communicable diseases. The entire General Assembly side meetings are focused on NCDs, non-communicable disease, specifically cardiovascular disease, which is the #1 killer of folks all over the world. Well, this has been a great conversation, and I want to thank you both, Drs. Mehta and Maddox, for joining me today for discussing how to address the cardiovascular workforce crisis and all the ways the ACC is working on this. As we've discussed, there are no easy answers and certainly no one-size-fits-all solutions, but we are making progress. Addressing these challenges requires sustained effort, collaboration, and a shared commitment, one that aligns fully with the ACC's mission to transform cardiovascular care and improve heart health for all. Before we close, let's raise our glasses to continued progress, to innovation, and most importantly, to a future where every cardiovascular professional is supported and every patient receives the care they deserve. Thanks for joining me today in a remarkable conversation.
Thank you.
Thank you.